Hello and welcome everyone. This is Dr. Asma Rashid from the Women Surgeons of Kuwait Research Network. Today our online session will be in the form of a journal club. So the students who have been working with us, they will be sharing the application of the knowledge that they have, and they will be critiquing some articles. So first we have our speaker, Diaa Soliman, a sixth-year medical student from Kuwait University. He will be critiquing the first article, which is a randomized control trial about Chinese herbal medicine formula for acute asthmatic. Our second speaker is from India. Her name is Katya Vidushi. She's a third-year medical student who will be also presenting another randomized control trial that talks about techniques for comparing two techniques in hernia repair.
Okay, so good evening, doctors and medical students and everyone here with us tonight. Thank you for taking your time and coming in today. I am Diaa Soliman, a sixth-year medical student at Kuwait University, and I'll be critically appraising a randomized control trial research paper. Please, if you have any questions, feel free to stop me anytime. So disclosures, the authors have no conflicts of interest to declare. So to start with, as you know, that randomized control trials is placed at the highest level of evidence for clinical research. And this hierarchy actually is made based on probability of bias. So as you can see here, that the randomized control trial have the least bias. How is it done? First of all, they get a eligible population, and then they stratify it according to higher risk patients and lower risk patients. And then they randomize it and they give the treatment group and no treatment group. And then they see the outcome, if they improved or didn't improve. So my research paper is about, the title is Chinese Herbal Medicine Formula for Acute Asthma, a multi-center randomized double-blind proof of concept. The journal is Elsevier, year of publication 2018, and the setting was in China. So what's my overview of my study? It's basically, they wanted to observe the efficacy and safety of a herbal medicine called PCYQ on acute asthma exacerbations, as well as to decrease the use of medicine, which is beta-2 agonist, which is used in treating asthma. So what they have done, they did a randomized double-blind trial for about participants who had acute mild asthma, and then they gave one group the herbal medicine, and the other group they gave a placebo, and then they saw the outcome based on the peak expiratory flow and as well as the cytokine level that's produced more in asthmatic patients. And of course, the results and the conclusions will be dealt with at the end of this presentation. Okay, so what's my PICO? As of course, you know that basically it's PICO, but because it's a randomized controlled trial, it's a PICO. The I is changed for the E is changed for I, which is intervention. So the P is a population, which is the participants with acute mild to moderate asthma. The I is the Chinese herbal medicine. The C is the compare group, which is they didn't give them Chinese herbal medicines. They just gave them a placebo. And the O is the outcome, which is the decrease the risk of acute asthma attacks. So how is the research question characterized? Basically, among patients with acute asthma attacks, does Chinese herbal medicine compared with no Chinese herbal medicine, which is the placebo, decrease the risk of acute asthma attacks? So, of course, to assess any research paper, we have to assess its internal validity as well as their external validity. For a randomized controlled trial, we have four major components. We start with the randomization, and then blinding, and then intention to treat, and then loss to follow-up. So for us to see a randomized controlled trial, we have to find these four major components. So first of all, we have to ask ourselves, did the research paper randomize or not? Yes, they did, because here they said that the proof of concept study consisted of a multi-center randomized study. The second part is blinding. So what do I mean by blinding? Blinding basically means there's two types. There is single blind, which basically means that only the patient or the assessor are not aware of the assigned treatment. And the double blind basically means that both the patient and the assessor are not aware. And this makes the research paper more evidence-based and gives it more weight. So in my research study, it was double blind, as you can see here. Okay, so intention to treat. The third component is intention to treat. It's very important in a randomized controlled trial to have an intention to treat. And actually, in my research paper, they did do intention to treat. So basically, what is intention to treat and why is it used? It's a very important concept, and I wish you guys understand it. So basically means that once you randomize, you have always to analyze. You always take into consideration any patient, even if they died, even if they didn't receive any treatment, even if they received the incorrect treatment. You never remove them from your study. I just want to give a fast example about it. So basically, this has nothing to do with my research paper, but I just wanted to make you guys get the concept of intention to treat. So basically, for patients with cerebrovascular disease, they randomized it according to one group. In the upper arm, they gave them surgery plus aspirin, and the arm that's down, they only gave them aspirin. And then they wanted to see the what do you call it? Like who got stroke. So in the surgery and the aspirin, the aspirin arm alone, 20 people got stroke. 20 people got stroke. However, in the surgery and aspirin alone, of course, we take like a month to prepare the patients to surgery. So 10 people got stroke before the surgery. So the question is, you have to ask yourself: do we remove the 10 people, or we leave it in our study? And here's when the intention to treat comes handy. So basically, if we, from the 100 participants, you now have 90 participants in the surgery and aspirin group. And from those 90, 10 people got stroke. So 10 over 90, that's 11%. So that means that 11% of people who underwent surgery plus aspirin got stroke. However, in the aspirin group, it's 100 participants, and they're still 100, and 20 got stroke. So that means that 20% of the people who have aspirin got stroke. So what's this showing? It's actually showing that the surgery and the aspirin group alone is doing a great job. But actually, is it? So basically, if we use this and ignore the 10 strokes prior to surgery, we get a relative risk reduction of 45%, which basically means that you have a 45% less chance to get stroke in the surgery arm compared to the aspirin arm alone. So this is actually called the per protocol analysis. However, if we did the intention to treat, basically it makes the two groups similar, as you can see. So the relative risk for the surgery and aspirin alone, if you don't remove the 10 people, we still have a 20% chance of getting stroke in both arms, and the relative risk reduction is 0. So basically, what intention to treat does is they make the two groups similar as possible, and they preserve randomization, as I said earlier. The fourth component is the adequate follow-up. So we can see that here in the Chinese herbal medicine group, they had 26 people lost to follow-up, and for the placebo group, 16 people lost to follow-up. But that makes it a total of 42 people lost to follow-up. So we have to ask ourselves, was it an adequate follow-up or not? We call it actually adequate if it's less than 10%. In our research, it's 42 over 300, which is 14%. So I guess we can call it's an adequate follow-up. So what happens if there is many dropouts from one arm or both arms in the trial? It depends. If like sick people, if more sick people leaves, that means there will be more well people that causes selection bias. So the other question we have to ask ourselves: did they take confounding into consideration? Yes, they did, because they did with respect to baseline demographics, asthma characteristics, baseline peak expiratory flow, and the comorbid diseases. And here, as you can see here in the table 2, they took it into consideration. Okay, so the last thing is statistical analysis. What did they use? They used the chi-squared as well as the p-value. And as you can see here, this is the result. So basically, the peak expiratory flow basically tells you how good your drug is doing based on the airway obstruction. So it actually improved. As you can see here, the red is the Chinese herbal medicine. So the peak expiratory flow actually improved using it versus the placebo. And the p-value for both of them is 0.004, 0.012, respectively, according to the morning and the evening. And for the salbutamol use, so it actually shows here that, as you can see here, the red is the herbal medicine. As you can see here, it actually decreased the use of salbutamol, which is a medicine to treat asthma. So p-value is less than 0.05. So this means that we do not reject the null hypothesis and conclude that there's a significant difference between the Chinese herbal medicine group and the placebo group in reducing asthma attacks, as well as decreasing salbutamol use. Also, the asthma symptoms decreased, which is also significant. Also, the cytokine assay, which is the interleukins, it's also decreased, significantly decreased. As you can see, the p-value is 0.022. So the overall assessment, so the internal validity, it was great. They randomized, they did blinding, they did the intention to treat perfectly fine, and the adequate follow-up was also fine. So what's the strength of the studies? It's the first well-designed randomized control trial to explore the efficacy and safety of the Chinese herbal medicine in asthma exacerbations. They took the internal validity into consideration, and they explored the possible mechanisms of the herbal medicine in the treatment of asthma exacerbation. So, of course, the weaknesses, one of the major weaknesses is the sample size. because they didn't analyze how the sample size is a reflection of the total real population, and they didn't document any type 1 or type 2 errors, which measures how well is the sample size in reflection to the real population. And the sample size was only 300, so I feel it's like a very little sample size. So weaknesses, of course, one of the major weaknesses is that they didn't measure the forced expiratory volume in 1 second and the forced vital capacity, which is critical in assessing airway obstruction. However, they use the peak expiratory flow, which is understandable because it's more convenient. And however, it's mainly used to monitor the compliance and your response to drug. It's not actually a measure for airway obstruction. And also, they measured the drug for 7 days, which is actually a very short period of time. And they didn't include a follow-up after treatment, so we don't know about the adverse effects of the drug. And they only restricted patients with mild to moderate asthma. And so we have to ask ourselves, what about the severe asthmatics that require steroids and hospital admissions? So the last question we have to ask ourselves is can we generalize that to our population, which is external validity? Before we do that, we have to ask ourselves some questions, such as like how similar is the study population, for example, China, from our population here in Kuwait? And you have to ask ourselves about the benefits versus the harms, the patient's preference, the availability, and the cost. So can we do it? I think we need more research regarding this because of the sample size. They didn't use an accurate airway obstruction measurement and the short duration of time, and there is no documentation of any adverse effects. I feel, finally, to move forward with this research paper, I feel that the researchers can validate patients with acute severe asthma in further studies, as they haven't in the study. Also, they should use a more accurate measurement of assessing airway obstruction, and also they should take into consideration the number of the sample size and using the type 1 and type 2 errors. And this is my references for the paper. And please, I will be very happy to answer your questions. And thank you so much for listening. And of course, special thanks to my supervisor, Dr. Rama.
Thank you, Leah, so much for presenting this article and critiquing it. Before I make any comments or your supervisor make any comments, I want to have the audience ask any questions that they have, and then maybe we can make a few comments. So please go ahead, guys. Okay, so I'm going to ask some of the questions. So we do have Leah with us today. I don't know, Leah, what do you think about what Leah just presented? Okay, we're gonna ask someone else. So anybody else? Yasmin, do you have any comments regarding the study itself? Are there specific questions that comes across your mind, for example, that Leah did not address when it comes to the study itself? And then when it comes to critiquing it in terms of the weaknesses or the strength of the study? So we do have a question. Yes, go ahead, Yasmin.
I would like to ask Diaa. It confuses me with my name. I don't know if he's saying Diaa or Leah. It's confused me. But my question for him was, what made him choose the study to critique, and what does he think the researchers could have done better to maybe have written the study better or make the study more efficient or to get better results, in his opinion?
Should I answer?
Of course you should answer. You're the speaker.
No, I mean, like, and I thought in the transition between, you tell me answer. Yeah, okay. So thank you, Dr. Aliyah, for your question. Actually, it was just random choosing this article because I remember the morning of me choosing this article, we had a session about asthma and like beta 2 drugs, and then like I thought about like I wanted to see the like any new research going on about asthma drugs, and then I found it, and I thought it's going to be a nice to critique this research paper. For your second question about like what I think the researchers should have done, I feel like they used the peak expiratory flow, which is it's a more convenient way of measuring the airway obstruction. However, it's not accurate as it's only used to measure like the compliance of your drug. Of like when you use beta 2 agonists, for example, you use peak expiratory flow to see your response to drugs. However, they should in the future they should use a more accurate measurement, such as forced vital capacity and FEV1. And also, of course, the sample size, it was only 300, so I feel also they should make it more than 300, and also like it should be a reflection to the total population, not only like one center in China. And of course, I guess that's it. And of course, yeah, like they only did it for 7 days, so that's a very short duration of time. I believe they should like do it for longer, and also they should have a follow-up of the patients to know that like if there's any side effects for the herbal medicine. And that's it. I hope I answered your question.
Yes, you answered my question very well. Thank you, Diaa.
So Diaa, if you don't mind to actually put up the slide of your where you have the title of your study, there are some questions and comments from the audience here. So we do have Dr. Bilqis saying thank you for presenting this amazing study. What are the ethical considerations in the study? She's asking.
Like ethics in terms of like using the drug itself.
I think that's what I think that what she means by her question. Are there any ethical consideration?
Like the authors, they didn't have any conflict to disclose. So it's not like a study that they tell us to take this drug. So I'm not sure if the ethical considerations.
So, yeah. So ethical consideration, for example, did the paper underwent an ethical committee to say yes, you can go ahead and do the trial?
Yes, actually. Okay, now I understand.
Okay. So yes, the answer is yes.
Yes, they did. We did have an ethical committee in China,
and
but
let me see. I understand what this means. Is there? So one of the things you have to think about when you want to do an intervention is that there are harm that is going to reach the patient, for example. So was this addressed in their discussion, for example, when they say yes, we obtained ethical approval, harm was discussed with the patient, etc., etc.
I don't think it's actually written in the study.
Okay, so maybe this is something should be more explicit. There is, okay.
Yes.
There is, Maha, please, Maha, we have Dr. Maha and we have Dr. also Mira. You can jump in at any time. We do have also another question which raised also about the same thing that you mentioned yourself. So you have Dr. Yasmin asking, you did very well. I have a question regarding sample size. Is there a specific cutoff for the number to trust a certain study? This always confuses me, and thanks.
Okay, yeah. So yeah, I believe it always goes with them. There is like there's this type 1 and type 2 error that you have to measure in a population. Like it's an equation to get to know like what and like there's applications as well online that you can use to get the true sample size from a population. For example, if you have a population, for example, of 2,000, and you want to know what's the exact number of sample size that's going to be eligible for your study, you can just put the numbers and then it will come out the sample size that you need. And you do this with type 1 and type 2 errors. However, in this study, they didn't mention any type 1 and type 2 errors that they have used to declare the sample size. So that's why I felt it's a weakness in the study. Okay.
All right. So you answered the question properly, and there are similar questions that talks about, because we know like if you talk about China, the numbers are like much larger than population like Kuwait. We do we did in our I'm gonna have maybe we'll have more discussion about the sample size with Dr. Akatia when she present her study, because we actually did for our colon cancer project that we're working actively now, and Dr. Akatia is one of the people who are working on project, is when we wanted to decide about our, for example, survey size that we like for how many people we should be sending the survey, we discussed the sample size, right? Because it's very important to be that you want your sample to be representative of the population. So maybe we can dig more into that when Dr. Katia takes her turn. Are there more questions for Dr. Diaa? And then I want to hear from Dr. Maha and Dr. Amnira if she's still with us. I think you did a great job, but let's see if they have more questions before we start complimenting you.
Thank you so much. I think there's more questions.
Okay, go ahead. Feel free to. Okay, I do have Amina also asking similar question about sample size. Still be applied to a smaller country like Kuwait, and would it consistent less or more problems in that case?
So do you think that the sample size? No, I don't think it should be applied to Kuwait now, because like we are not sure about like still there's a lot of things that you have to take into consideration. For example, you have to take into consideration the adverse effects. The duration of period is only 7 days of the drug, which is very little, I believe. Also, of course, the sample size, even if it's 300, I feel it's less. It's very little here in Kuwait. Would it constitute less or more problems in that case? I don't get the next question.
I think she's talking about the sample size.
Yeah, I think we need more cases it all comes up like when you calculate your actual sample size in Kuwait, or what's your actual target. So I cannot answer this question actually. Okay,
let me ask you a question, Leah, because I think you did very great. So I don't know if you mentioned across as you went. So what was the co-founding factors, for example, in this study? What would you say was the confounding factors?
The confounding factors were the demographic data. So, for example, some people who live, for example, in places that exacerbates asthma, so they took that into effect, and also some people who actually had a family history of asthma, they took that into effect. Also, let me check this one.
Because especially China, right? It's like a very industrial area. You don't know like where these people live.
Exactly. Yeah. So they actually, they did a good job.
But it's something. Yeah.
They even took into consideration everyone, like if they have any comorbid diseases, they took into consideration their duration of taking the drugs, all types of drugs that treat asthma. If they are current smokers, if they are men, or their BMI, like if obese or not. So I think they did a very good job in controlling the confounders.
Okay. What about the information bias? Like, do you think, for example, the blinding was done appropriately? Was there an issue with their blinding?
I think it was fine. The blinding was fine. Like the author, neither the participant knew what they were taking. So I guess it was okay in terms of blinding. All
right. I think Maha, Dr. Maha, I'm gonna give you the mic now because I don't have more questions, and we do have our, I think, second speaker in the audience, so we can ask you for any last comments before we move on for the second speaker.
Sure. So to start with, Leah, you did a great job, and I must commend him on his work. This was mostly, he did most of the work and he did most of the analysis, and I just added some comments here and there, but not really any major comments. Sample size is something that we discussed a lot, and it's very important to keep it in mind in any project and really calculate it, because it really gives you the power of your study. You want to decide what the power of your study is, and based on that, do a sample size calculation. And it's going to differ in which community you're covering and what kind of disease you're covering. And this is something you can discuss in detail with a statistician that you're working with, that you should involve early on. But it's definitely something very important to cover and to calculate, because it will influence your study. Again, I don't really have questions for Leah. I asked him, I grilled him on all the questions before the talk, and he did a great job in covering them. And
thank you so much,
yeah, and he was ready for answers, don't you guys think? So great job. You covered it in a good time. You allowed for questions, and it was very clear, I think. Thank you, Leah.
Thank you so much, Salama. Thank you so much.
Thank you, Leah. And if I am to add one thing, and I think you did great. The only thing is that I would speak slower, because you have to cater for all the audience. I think at some point in terms of your presentation, you were a little bit fast, but I think you did great overall. Well
Thank
done.
you so much, Dr. Asma. But because I was so short in time, and Dr. Maha was like, yeah, only 7 minutes. And then I was scared that I don't have the time to finish it.
I need to comment also, Dr. Munira معك. Very nice job, Dr. Diaa, Dr. Maha. Very clear presentation. You had it, and you were very nice in answering questions. It seems that Dr. Maha prepared you very well for all the questions.
Yes, she did.
Very nice. Excellent presentation. Excellent.
Thank you so much, Dr. Munira. Thank you so much.
Thank you, everybody. We're gonna now switch gear, and we're gonna talk. We're gonna have Dr. Akatia to present. So Dr. Akatia joined us just late. I'm gonna just share this. Here we go. Here, so we have Dr. Akatia Vidushi, who works with the Colorectal Cancer Project, gonna join us today and present her article. Okay, here we go. So go ahead, Akatia.
So my name is Diaa Vidushi Sinha, and today I'll be discussing on the comparison of treatment outcomes of surgical repair in inguinal hernia with classic versus pre-peritoneal methods on reduction of post-operative complications. Introduction. So as we all know that hernia generally means weakness or defect of the body wall muscle fibers that provide a space for protrusion of the internal organs. It is seen that inguinal hernia is divided into two categories, direct and indirect, which includes 24 and 50% of all types of hernia respectively. Now, surgical treatment is basically the choice treatment for this disorder, and there are various methods accordingly and respectively. Here in this study, there were two procedures which were studied on. That was the classical and the pre-peritoneal methods. The classical method is an easier method than other methods of repair, which is performed by surgeons. And if it is gold standard of herniorrhaphy. So moving ahead. The aims and objective of the study showed that they wanted to evaluate and compare the results of inguinal herniorrhaphy with mesh in classic and pre-peritoneal method in general hospitals in Iran. Material and methods. So here, if you can see that, firstly, the ethical statement was obtained by the ethics committee of the respected university, and also a written informed consent was also obtained from the participants before their surgery. Coming to patients, so about 150 candidates were enrolled for this study, and both the methods, that is the classical and the pre-peritoneal methods, were explained to them, and they were also ready to take any consequences later on in the future, and the participants were also given the chance to withdraw from the study if they do not wanted to participate in the study. Now, the surgical procedure, what exactly they went about was that the patients were randomly assigned to two treatment groups, as it was a RCT. So the patients underwent surgical repair in inguinal hernia with classic versus pre-peritoneal methods under spinal anesthesia. In both the groups, the surgeon incised the skin and subcutaneous tissue of the lower part of the abdomen, and then the fascia of scarpa and the root of the inguinal canal. Now, the first group, which was assigned of the classic method, after reinforcement of the posterior wall of the inguinal canal, the Marceline mesh was placed and fixed using the round nylon stitch 3/0 to the edges of the defect or weakness of the posterior wall. Now, the second group, which was assigned to the pre-peritoneal method, briefly, after acquiring the posterior wall of the inguinal canal. The mesh was placed and fixed using the same round nylon stitch 3x0 under the posterior wall, and then was rehabilitated based on modified Bassini repair method. All patients were then followed up for 6 to 12 months after the surgery. Moving ahead, so the inclusion and exclusion criteria. So the inclusion criteria, they involved all the participants which were having direct hernia with defects in the posterior wall, and a candidate for classic herniorrhaphy, and also for preperitoneal herniorrhaphy and satisfaction to enter the study. While the exclusion criteria included diabetes, bleeding disorders, and aspirin and corticosteroid consumption. Both the groups were compared after the surgery in terms of recurrence, pain, seroma, and hematoma in 3 to 12 month period. So basically, the following terms, recurrence, pain, seroma, and hematoma, were identified as the distinguishing factors between the two methods. So coming to the results, so the total, as we saw earlier, the total sample size was 150 patients, of which 75 were assigned to the classic method and 75 to the preperitoneal method equally. In the classic group, 64% were males and 36% were females, whereas in the preperitoneal, 54.7% were male and 45.3% were females. Now coming to the areas of distinguishment. So the first criteria was frequency of the post-operative pain. So this was seen higher in the classic group, which constituted about 21 and 28%, and lesser in the preperitoneal group, which was 12% only. Also, the same recurrence and the frequency in numbers was seen in the rate of recurrence, the second distinguishing factor, as it was seen higher in the classic groups, constituting about 13.3% and 2.66% in preperitoneal group. Moving ahead, so the third distinguishing factor being the frequency of post-surgical hematoma, which was also a very important factor, showed that there was an increase in the preperitoneal group, that's constituted about 12%, and on a lower side, which was seen in the classic group, about 9.3%. Finally, the rate of post-surgical seroma. So this was the last distinguishing factor, which constituted a higher in a classic method, being 10.7%, and really low in preperitoneal method, which was 1.3%. Coming to the discussion. So here in this paragraph, I have highlighted the main points. So after doing the study, both comparing the classic and the preperitoneal methods were discussed and were seen in various under various distinguishing factors, with the scores of quality of life, including the physical and mental health, were almost similar in all the methods with mesh. But also they had also a significant difference in comparison with the tissue repair method. Therefore, the rate of recurrence, post-operative pain, and hematoma was significantly lower in the preperitoneal group compared with the classic one in this study. And that is why the pain is higher in the classic method, which may be due to the direct contact of the mesh with the spermatic cord. And finally, it seems that through the study, it was proved and shown respectively that the preperitoneal method is a more suitable method for inguinal herniorrhaphy than the classic one, because of fewer complications, according to the findings of the study, as we saw in the results section. So it should be noted that the determination of the type of operation needs a lot of benchmarks, and medical staff should also perform the most appropriate procedure according to all aspects to treat the patients, and here in this case should be the preperitoneal method. With this, I here attach the references of the study. There were about 15 of them. Thank you.
Thank you, Katia, for your presentation. And thank you for sharing this article with us. I know you picked the article very tight on time, so Katia actually picked the article yesterday morning. So well done on the preparation. So I'm going to open the floor for people to start asking you questions before I'm going to ask some of the questions that I had on this study or make comments. So or let me just start by saying, for example, if you are to mention, give me like 2 or 3 of the weaknesses of the study or the benefit, like the strengths of the study, while we get some of the questions from the audience.
Okay, so the first, I think the weak point was the sample size. I think they could have approached a bigger sample size, as there is an RCT, and as we discussed in the earlier presentation as well, to get a better and a clear picture. I think they could have done on a bigger scale, at least reaching to about 300 or 400 patients. And while talking about the benefits, I think the way and the factors which they chose to distinguish between the two surgeries and methods, I think that was something which I think was good in the entire study.
Okay, so I agree with you on the sample size. So we do have some questions here. I think Diaa raised his hand. He wanted to make a comment. There is one question here as well that says, has this study already been used to change practice guidelines in Iran? So I'm gonna have Diaa ask you the question, and then you can maybe answer that question after. Go ahead, Diaa.
Yes, thank you, Dr. Katia, for this presentation. So surprisingly, you and me, we have the same study design, which is a randomized control trial. I just wanted to ask you about about the internal validity. Like, did they take into consideration the 4 components like randomization, blinding, intention to treat, and adequate follow-up? Thank you so much.
Thank you for your question, Diaa. So they did try to follow the guidelines to change the practice, but it was not very well shown in the study and also in the entire thing. So I don't think it was really followed up.
Okay, that's great. So I agree with you. I think one of the most important things that you have to think about when you talk about blinding in surgical studies is sometimes you cannot blind the surgeon in certain aspect when it comes to doing the surgery. But I do have some questions regarding that. Now, so you already answered the questions about changing the guidelines. So as surgeons, for example, okay, here. So Yasmin is asking, was there any confounding factors accounted for in the study?
No, I don't think so.
Okay, so Dr. Munira, do you have a comment?
Yes, I do have. First, for the follow-up, and usually 6 to 1 year, 6 months to 1 year follow-up in recurrence of hernias is a very short follow-up period.
Exactly.
Usually you need more than that. So this is, I think, one of the weak things. And then regarding the surgical procedure, I don't know, Asma, you are more into surgery than me, but they're comparing a tension-free to a tension. In the pre-peritoneal, they're doing Bassini repair on top of the head, on the mesh placement. So they're comparing 2 different, tension-free and tension. So how is that?
Okay.
Is it difficult to do that anymore? Bassini, anyone who's doing Bassini?
So here, so I think, so this is one of the things that I was going to talk about, is that when we talk about doing randomized control studies in surgery, 1, blinding is an issue, but number 2 is the technique. So in the paper, they did describe their technique, which was okay, but one of the confounding factor, I would say, for example, they did not mention the level of training of their surgeons. They did describe the technique, they did put the mesh underneath the transverse fascia in this study. They want to say that the pre-peritoneal is probably better, which they showed from what they said, but again, giving the point that the size was not adequate, for example, and they did not mention anything about the their surgeon. So if you're comparing a result, for example, between a general surgeon versus somebody who have different level of training when it comes to hernia repair, when they looked at the outcome and they looked at the complications, I 100% agree that hernia usually occurrences, when we look at them, we look at about the cutoff of 2 years. So their general, I think I remember that they put in its the rate was in the 4%, the recurrence rate, which is closer to like international standards. But they didn't mention what was the criteria, like, sorry, they did mention that it's 6 to 12 months, but how many have followed, and they still had around that rate. So so I'm not sure, if you have followed these patients even longer, if that would be if that would give us a different result. Okay. Other things that I want to comment on is that they talked about the complications, but the complications they have mentioned are a bit subjective, and they did not clarify. Maybe they did in the study, but they did not clarify how objectively they assessed their hematoma. Based on what? Was it a little bit of bruising? Was it larger bruising? What was the size that the patient needed transfusion or not? Like these things that gives you more objective way of looking at hematomas, that was not addressed. And then the other thing was about the pain, for example. So if you want to talk about a specific type of hernia repair will result into less pain, first of all, you need to know, you need to be objective in terms of assessing the pain. So maybe they did, and then they did their statistical analysis on that, but they did not tell us how did they measure the pain for the patient. So we do know that there are validated ways of measuring the pain. So these are, I would say, some of the areas that they could improve on, looking at their hematoma, pain, and then their surgical technique. If they're using classical surgical technique, was this surgeon's standardized, for example? They could say, for example, so you could do it either by a single surgeon, so one surgeon would do all the cases, versus you would have two people have similar level of training doing a procedure. So that would, I think, adjust for that. So this is just in collective some of the points that I have to comment on that.
Also, Dr. Asma, can I comment?
Yeah.
Also, for the patient, they just said male, female, and you can see that female are more in the second procedure. They didn't even mention the age. Maybe one group is younger, one group is older, one group is more active, lifting heavy weight, so it has effect on the recurrence. They didn't mention the demographics.
So that's why, yes, I think Yasmin mentioned earlier about was there a confounding factor. They did, I think, exclude the pregnant woman. But I am not sure about, for example, patients who are diabetic, patients who have issues with wound healing, for example. They did not, again, with the size of the study, I'm not sure if we will be able to say what is confounding, because the number is not very big. But also we discussed the sample size issue that they did not mention it. Have they calculated it? Was it appropriate or not? In order to say that has a good power. But I think the great thing I think is that we have two different studies, both randomized control trials, looking at different things. But yet I hope that tonight we can actually see the commonality of how, like you're talking about two different studies, but we're talking almost about the same things when we come to like a critique them, look at their weaknesses and their strength. So if nobody have more questions, I want to ask actually the two speakers that we have today. Both of them did a great job. I want to ask them, what have you learned today from, so you guys like read the article, you went in and you looked at what are the weaknesses, what are the strengths, did they answer the question, etc., etc. But what have you learned today after all these comments, questions, and so forth? We'll start with Diaa and then we'll go with Dr. Katia.
Of course, I learned a lot. It's a great learning experience. I think it's my first time critiquing a paper. I thought I would never do it, and it happened. So it was a very nice experience, and as well as, mashallah, and Dr. Asma, Dr. Munira, Dr. Maha, and all the doctors here with us are all well known in Kuwait in surgery. So, and they are listening to my presentation. So it's an honor to me, to be honest. So it's a great learning experience. Okay,
that's great. But I mean, in terms of like specifically for your study as well. Okay. Dr. Katia?
Yes, ma'am. So this was the first time I ever presented in a journal club, and I think it was a great learning experience. I learned a lot, starting from how to critique a paper, and how to present it accordingly with with all keeping everything in mind, and seeing the factors, the contradictory factors, and the factors which really needs to be put out there. I think it was a great experience to have been a part of. And I also like surgery is something which I haven't really started in my medical school yet. So this was a great like a introduction for me, and I learned a lot. Like, yeah, thank you so much.
It is actually our pleasure to see all of you thriving and learning, and that's the whole purpose of why we are doing this. So thank you everybody for coming here tonight. I know that many of you like tired and exhausted, and it's the end of the day, so I don't want to keep you longer. But we're so proud of all of you, progressing and doing great. And inshallah, there will be more chances to present your work. And this is an open invitation. So we will be having our like next week and the week after, we will be having 2 online sessions by faculty, but also after that, and hopefully throughout the year, there will be always time to go ahead and do journal clubs. So if, at any time, at any point of time, feel free to send us an email if you want to present anything. We talked about randomized control trial, but we did not critique other type of studies that that will be critiqued differently as well, and will add definitely, inshallah, to everybody's experience. So feel free to send us an email or speak to your supervisor if you want to do that. And we really want to, we are like proud of your work, so we will be happily uploading this video in our website, and hopefully we'll have more activities led by our students and our residents. So thank you everybody, and have a great night.